So I'll be talking about almost the same situation, the management of femoral bone loss. So friends, managing femoral bone loss is a complex situation. And one most important issue is that you must have a full length x-rays of the femur, otherwise you may end up missing some problem downstairs. Pavlovsky is most commonly used classification, and it depends on the degree of residual proximal femoral bone stock and the residual isthmus available for diaphyseal fixation. If it's more than 4 centimeter available, then it's 3A, and if it's less than 4 centimeter scratch fit, is then 3B, and totally unsupportive is 4. And then there are few things which Pavlovsky doesn't cover. It doesn't cover the stenosis, malalignments, and periprosthetic fractures. So you can end up using the combination. And the implant selection is dictated by the quantity and the quality of the residual bone. And friends, the tapered fluted stem is the workhorse of the revision, as Bose told us that 90% of your revisions can be done with tapered fluted stems. But of course, there are other options like impaction bone grafting, and then cemented or a non-cemented stems, or long cemented stems, very rarely used. Then furicose supported stems, they are moved out. Then there are some cases which can be managed by short stems as well. Then allograft, mega processes, full femur replacements are the other options. But remember one thing, that you must obtain rotational and axial stability of the component in the very beginning. And you need to maintain the center of rotation of the hip, maintain the offset and the leg length. And cementless devices are more commonly used. But you shouldn't forget one thing, that you need to think about the future revisions. Use as short a stem as possible in the first revision. Stems he has already talked about, and the most commonly used is now tapered fluted stems, but short stems have a role to play. And then, of course, extensive implants like full femur replacement or proximal femoral replacement or allograft, impaction bone grafting. Of course, I have no experience with the impaction graft or these stud grafts. So let's talk about different types and different options. Type 1, minimal metaphyseal bone loss. So you can end up using the standard stems, or you can use short stems as well. Rarely you will need tapered fluted long stems. Couple of examples: infected situation, 2-stage revision, primary stem. Another septic loosening, 2-stage revision, cement spacer, and then a short stem, and this is 3 years follow-up. They do work in selected patients. Another, this was done with a modular sleeve. This was 10 years ago, a good follow-up. So you can select any of these implants according to the given situation. Then type 2, little more extensive metaphyseal bone loss, but no or minimal diaphyseal bone loss, and then you have different options. Again, taper fluted is the workhorse in different cases. Infected situation, 2-stage. This was the stem being used long time back, but now it's obsolete, but it worked in some situations. Again, 2-stage revisions, and there I used short stem, and I reconstructed the acetabulum as well using the equine bone, and this is 5-6 years down the lane. And use of short stem is, or the primary stem for revision for grade 1 to Pavlovsky is very well documented and supported by the literature. And use of short stem in younger patients for revision is also pretty well supported by the literature, with a very high survivorship of 95% at 5 years. And then more extensive bone loss, 3A, you have more than 4 centimeter scratch fit. Then again, there are many options, but the most popular option now is tapered stem. A couple of cases, cemented stem, and then this was revised with a reef stem. And this is 6 years, 7 years follow-up. Subside molar stem revised with a long stem. Infected situation, two-stage revision. I didn't do ETO in this patient. I just did a window and then a modular stem, and I had to reconstruct the acetabulum also using cup and cage. Periprosthetic fractures, although Poprosky doesn't cover it, it's covered under AOS. Long stem, whether modular or non-modular, will work. Similar situation, a non-modular Wagner stem. And then many of these trunions fail. This was a particular kind of trunion with some company, a number of revisions. And then coming on to 3B, more extensive metaphyseal and diaphyseal bone loss, and less than 4 centimeters available distally. Still, you can solve many of these patients with taper stems. A couple of examples. Modular taper. Very interesting patient. Extensive cementing done by somebody else, and a lot of scalping from inside. Stem was loose, cup was loose, so I could remove the stem and cup easily. And then I was in a fixed which implant I have to use and how to remove the distal cement. So I did a transverse osteotomy, removed the distal cement, and did a long tapered fluted stem, and it worked pretty well. Then coming on to type 4, very extensive bone loss. You have a couple of options, and just two cases. This patient had a long history, done 30 years ago, cemented Charnley, then revised porous coated, which broke at 2 years, then revised with a tapered stem. Again, it subsided, and we revised it with proximal femoral replacement, and it's now 4 or 5 years down the lane. Another one did about 10 years ago, still working well. The patients which Poprosky doesn't cover, just 3 more slides, the femoral stenosis. And short stems are the best options for these patients. You don't need to go across that femoral stenosis. There is no way you can go across that. So this one of the very good options. Then deformed femora, again, is a good option for meta stems. So friends, Poprosky 1 and 2 can be easily solved with primary stems or short stems. And Poprosky 3 and 4 need more extensive surgeries, longer fluted stems. There is a place for impaction bone grafting, but I have no experience with that, and no experience with APC or PFO. Thank you so much.